Thank you very much. Good evening, ladies and gentlemen. Thank you, Abdullah. Thank you for Professor Gusibo Rosano also for coordinating this nice course. Now, Abdullah gave me a very tough on implementation dual antiplatelet. These my disclosure. Now, I subdivided my talk into what is the ideal duration of dual antiplatelet therapy, and also, the guidelines of acute coronary syndrome. They released it in last August, and I'll show you today a trial where was presented last October in TCT called TPAS trial 2023. Of course, the guidelines, the European, I will just go quickly because Professor Majdi Abdel Hamid, Dr. also Fakhruddin have passed through it and in details, just quick. But what I'm showing also two important things. The Canadian guidelines focus update just released last October, and I'll also show you a review article published just last month in November about the monotherapy. So what is the ideal duration of dual antiplatelet therapy, ladies and gentlemen? This duration, i.e., should I go 3 to 6 months? Should I go 1 year beyond? It's really individualized. It is not a clear, not for all, but it should be individualized, and you should take into consideration factors or tools such as precise DAPT score will help. And if it is increased risk of bleeding, you shortening. If it is low risk of bleeding, you go to 1 year. And then you should take into consideration the patient-related factors and the procedure-related factors. Type resuscitation makes a difference, acute coronary syndrome versus elective PCI, stable or chronic disease, chronic stable angina. Comorbidity, atrial fibrillation, very important, the presence of anticoagulant and chronic kidney disease. Also balancing between bleeding risk, ischemic risk, and procedure-related factors, PCI and type of a stent. So if I want to put them in table, this is the table show you that shortening less than 1 year, 3 to 6 months, you have to take into consideration patient-related factors, as I mentioned. So if the patient is stable coronary artery disease, no risk of bleeding, short lesions, single vessel disease, in new generation of stent, definitely you might consider it 3 to 6 months. And if it is patient complex cases with a lot of comorbidity, anatomy-related factor, long lesion, complex bifurcation, those you will consider long duration, 12 months, and perhaps beyond that up to 3 years. We all talk about high risk, bleeding risk, and ischemic risk. What is the definition of high bleeding risk? I will come to that because should we have a criteria? We do have a criteria. The Canadian told us about it, and I'll show you. So let us present TPAS, which was presented in TCT last October 2023. And this is the first time to present less than 1 month of dual antiplatelet therapy followed by ticagrelor monotherapy after acute coronary syndrome. And this is done by the East Asia in in Korean. And the background behind it, because they have a data, TICO also from Korea, Twilight by Roxana Mahran and the group, they demonstrated that ticagrelor monotherapy after 3 months of dual antiplatelet therapy significantly reduced bleeding risk without increasing an ischemic event in patients with high risk PCI. So the objective is to test for the first time whether we can use less than 1 month of dual antiplatelet therapy followed by ticagrelor and compare it to usual dual antiplatelet therapy, testing for non-inferiority, and if it is positive, then we'll go for superiority. Study design, all 24 centers in Korea, patients with acute coronary syndrome, among them 40% with STEMI and 29% with diabetes. This is the design, ladies and gentlemen, 2,850 patients randomized into ticagrelor monotherapy, 1,426 versus the dual 1,424. Testing the primary outcome is the net adverse clinical event, NACE, at 12 months, and that constitutes the major bleeding BARC 3 and 5, a major MACE, MI, stent thrombosis, and stroke. Now, the median use of aspirin, ladies and gentlemen, is 2 weeks, 16 days, 16 days. About 10% could reach, or less than 10% of total population reach at 30 days. So 90% went to the median of 16 days. And what it showed, ladies and gentlemen, the NACE, the net adverse clinical outcome, showing that in the less than 1 month monotherapy, the yellow line, events is 2.8 versus the usual 5.2, with hazard ratio of 0.54. Relative risk reduction is about 46% relative risk reduction, with meeting the both non-inferiority as well as superiority, with landmark analysis of 1 month and onward with the separation of the curve. Of course, the major bleeding was the major drive for the NACE. As you can see, 1.2 in the monotherapy versus 3.4, with the relative risk reduction of 65%. Now, the MACE, the death MI stent thrombosis, although numerically lower, 1.8 versus 2.2, but this did not reach a statistical significance. In addition, for the major bleeding BARC 3 and 5, you will see also BARC type 2 bleeding was significantly lower with ticagrelor monotherapy. Now, the limitation, the study is underpowered, and also is an open label trial, not a placebo controlled. So the conclusion of this trial presented last October, ladies and gentlemen, less than 1 month of dual antiplatelet followed by ticagrelor monotherapy met the inferiority and also superiority, mainly driven by the reduction of major bleeding. And this study could provide evidence that stopping aspirin within 1 month after implantation may be reasonable alternative to the longer, particularly in a patient deemed to be with a very high risk of bleeding, particularly with a previous risk of bleeding. The guideline, the American, has been mentioned many times. No need to go over it, but just let you know the guidelines was in August. The TPAS was in the October. We talk about, Dr. Fikri Deeb has mentioned about the anticoagulant. Now the strategy to go 1 week of triple and then double. Only you go 1 month if your ischemic event or risk is very high, and then dual therapy after that. Now there are some debate that what you will do after 1 year if the patient is a very high ischemic risk with multiple PCI, left main, previous stent thrombosis. Should you give SAPT in addition, or you go with monotherapy? These not mentioned in the guidelines. Now let's talk about the Canadian guidelines. Focused 2023, we're focused on the 2018. This is published in October 2023, so 2 months ago was published. And they mentioned about the bleeding avoiding strategies, like avoid pre-treatment in patient with more than 24-hour presentation of acute coronary syndrome. Very important, avoid bridging when interrupting oral anticoagulant. Use radial access. Avoid glycoprotein 2B3 inhibitor unless bailout situation, and use proton pump inhibitor. And the Canadian guidelines, our focus guideline, they mentioned about the definition of high bleeding risk, ladies and gentlemen. There is a major criteria. You need only one to make your patient high bleeding risk, and you have 2 minor in the yellow. Any 2 of them, they make it the definition of high bleeding risk. And on the left side is the risk factors the patient taking in consideration to call the patient high bleeding risk. In addition, this Canadian also mentioned about the criteria of complex PCI. The figure showed nicely anyone of the criteria deemed to be one enough to call the patient a complex PCI, 3 stent, long stent, 3 legion, multi-vessels, bifurcation, left main, uses CTO, uses atherectomy, any one of them called a complex PCI. The difference here is not different from the other, the European. They are mentioning the same, but they mention the extended in one arm. You can go up to 3 years of dual antiplatelet therapy, patient on again, and patient bleeding risk, ischemic risk, the standard 1 year. Now, in 1 year, when they go, of course, they all prefer when you use initially ticagrelor or prasugrel is preferable over clopidogrel. They mentioned for the first time the de-escalation, although yellow means weak recommendation, it's not as strong. Also here mentioned about if the patient with a STEMI or coronary angio more than 24, you need to load the patient with in addition to aspirin, ticagrelor is preferable over the clopidogrel. You can stop the ticagrelor 3 days and clopidogrel 5 days. And this is a new recommendation, ladies and gentlemen. Patient post-CABG, aspirin, resume aspirin as early post-operatively. And the patient had acute coronary syndrome, either off pump CABG or on pump, you give dual antiplatelet therapy up to 1 year. And this is to improve the graft patency as well as reduces MACE. So this is considered new in comparison to 2018 guidelines. And this is triple therapy, again, no different from the European in terms of the strategy of how to manage addition of anticoagulant with the dual antiplatelet in AFib and PCI. Last but not least, in the last 2 minutes, ladies and gentlemen, I came across a few days ago on this nice review article published just last November 7, 2023 in Circulation Journal. And what it showed summarizes the short therapy. You can see taking into the global leader with acute coronary syndrome, Twilight, acute coronary syndrome, TICO, Smart Choice, and Stop DAPT, acute coronary syndrome. And then you can see in terms of major adverse clinical event, on the left side is monotherapy, no differences as touch unity. But when it comes in sense of major or minor bleeding, of no doubt that all these trials, now you add to them also the TPAS, you will see clearly that there is a significant reduction of major or minor bleeding, about 46% relative risk reduction. Well, this will change the guidelines because the guidelines just released, but this is the future of all the trial. This is my last case. These are TPAS I have presented for you. All of this is short trial, short dual antiplatelet, 1 month versus 3 months, most of them 1 month. There are 5 trials, the 6th trial, one of them I presented TPAS. We'll hear in the future about the bulk STEMI trial, ultimate DAPT, target first, a new mind, and May trials. And these trials, as I said, showed in the blue dark box is the duration, 1 month versus the monotherapy. I think this will give us more insight. Should we go with 1 month? Should we go with the 3 months? And I think this, after all these trials, the guidelines might change from 2B to 2A or maybe to 1, depending on if they have a consistent results showing a benefit in terms of bleeding risk reduction without increasing the adverse MACE. By this, Mr. Chairman, dear colleague, I end up my talk showing you the update, and thank you very much for your attention.